Well, welcome everyone. Excited to share with you all a little bit about getting started with CTAK, how to establish the surgery in your practice, and a couple of pearls on my first series of cases, and how to make it work for your office as well. So let's talk first about what is CTAK. The basic idea is that we're using allograft tissue to treat patients that have irregular astigmatism, to normalize their cornea for patients with keratoconus and other forms of ectasia. Importantly, it's customized tissue. So we're able to customize thickness, arc length, optical zone, and so on and so forth. And we're able to apply customization by using preoperative tomography from a pentacam or Galilei. It gets run through CorneaGen's nomogram through Peter Hirsch and Steve Greenstein, and then cut to specification. So how does that work? So let's first talk about surgical planning. So how this is going to work, you're going to find a patient. We'll talk about a great first candidate for you. You're going to find a patient. Already you have your pentacam or Galilei images on the patient, and then you say, okay, I'm going to schedule you for this procedure. Schedule them, 6 to 8 weeks out, couple months out, to give yourself time to get the tissue, get everything sorted. You're then going to take that tomography data and you're going to upload it to CorneaGen. It's all a very streamlined process, very user-friendly. You can either install their software on your pentacam, which will data dump it directly to them, or you can export the U12 file from pentacam. And if you're wondering what's the U12 file, go on YouTube. There's like a 40-second video. You just select the patient, hit export. It'll come in as a U12 file. You can send that over by email. That data dump will inform CorneaGen how to apply the Hirsch-Greenstein nomogram to customize your tissue. They'll look at the tissue, and then they're going to come back to you with a proposed surgical plan. And this is what that surgical plan is going to look like. There's a number of different things that they're specifying. It's a little bit noisy here, but I'm just going to break it down. So the first thing that you're going to see, basically 3 different major areas of customization. The first is the arc length. That's going to be fixed by the nomogram. So if you see the arc length is given by, I don't know if my mouse is working up here. No, it's not. So I'll just show you up here. This arc length is going to be given by the nomogram, and it's fixed, and it's going to be given by edge 1 and edge 2 angle. Right? So edge 1 angle, 75 degrees, edge 2, 105. That's going to be fixed. What is also going to be fixed is the centration. So CTAK is centered on the cone rather than on the pupil. So we'll see that it's important to take from pupil center these margins so that you know exactly. Here it looks almost on the pupil, but if you have a cone that's a little bit more eccentric, you'll see that that CTAK inlay is actually decentered relative to the pupil, right? So that's given as well, and those are your offsets: inferior offset, infratemporal offset, and temporal offset, right? That's all going to be given, right? What you're going to, and then the diameters will be given. So you have an inner diameter, and then you have an outer diameter. So in this particular case, your inner diameter is 4.5 across the board, and 8.0 across the board. So we're relatively tight in the optical zone, and we have a wider inlay. That speaks to kind of the heritage about how CTAK came about. It's more of a lenticule addition surgery that became more annular over time. So contrasting that maybe with CARES, which is a little bit more peripheral, very thin segments, these are coming much closer to the optical zone. They're more customized in terms of your thickness, and they're a lot wider and flatter. So that all is given for you by the nomogram, which again, CorneaGen's going to run this on the background from your tomography. They're going to give you then some options here, and this is for you to specify as a surgeon. You're going to get a thickness choice. Option 1, option 2, option 3. They're going to tell you what the nomogram recommends, and then you get to choose your thickness. And the question is, why would I defer from what the thickness is there? It's based on the amount of flattening that you want and what that patient's preoperative refraction is. So if I have a patient that is significantly myopic and I want a big effect, I have a lot of room for flattening. I might go for more than recommended in terms of the thickness. I've got a lot of irregularity that I want to treat, so I don't mind going thick. If on the other hand I have a patient that's mild and their spherical equivalent is a diopter, 2 diopters on the minus side, I might not want to go with the recommended or with the very thick. I might want to go with something a little bit, because you don't want to shift it. You want to flatten the cones. You don't want to shift these patients into hyperopia, right? That can be problematic. So that's the option that you have there as a surgeon. And then you, of course, with that inlay plan, it's then going to be processed and CorneaGen's going to ship it to you. Any questions for me on how to get to this screen and then what your options are on this surgical plan? Or is this all pretty straightforward so far? Great, so now let's talk about day of surgery, surgical technique, how this is going to look. And what I'm going to do is I'm just going to take us through a case here to kind of put it to life, so to speak. Here's a patient with moderate keratoconus, right? And this is a nice starting configuration in terms of choosing some of your early cases. Moderate keratoconus are nice patients to start with, right? They have a lot to gain because they're not mild, right? But the advanced patients are a little bit trickier. Some of them may remain RGP dependent for their best vision or may need secondary procedures. So pick your first patients moderate, I would say. And we'll get into case selection in a minute, but I also like this conformation for your first cases. This snowman conformation. This is your most typical conformation for keratoconus. These are nice. I think that these are the most predictable by the nomogram in terms of the reshaping, right? So this is what we selected, and we had our design options come about, right? And again, we have our angle of placement, right? Our meridian was given to us, edge 1 and edge 2 angle, boom and boom, right? We have our offsets are given to us relative to the pupil center. We have our inner and outer diameter that are given to us. And then we have options for our thickness here. And I selected for this patient the recommended thickness. But this comes to you, the surgical plan is going to come to you within a few weeks, typically, of your uploading the relevant details. As soon as you get the surgical plan, you respond. CorneaGen's been great in terms of responding then to that surgical plan in terms of processing tissue, cutting it, and getting it back to you. So how much lead time are you all recommending between seeing the patient in the clinic? Between seeing the patient, sending them to a surgical coordinator and say, I think this case is going to happen in 2 months, 3 months. What do you guys think? 2, I think, is what I'm doing. I kind of do 6 to 8 weeks and I push them. I'm kidding. I would never advise that in front of an audience like this. But you want to give them some space, right? And usually it takes that amount of time also for the patient. They're young patients, right? Typically they got to take off from school or work, right? And there's typically some insurance things that you got to get through as well. So, a couple months is usually the amount. And in that length of time, they're pretty good. Surgical plan, choosing it, right? And then we get to the day of surgery. So let's go through that surgery now. So this is how the tissue is going to come to you. So this is, first of all, it's gamma-irradiated tissue. So this is acellular, right? It's going to come to you in a storage medium, shelf stable, at room temperature. And it's similar to if you've used their patch graft tissue, their vision graft tissue, you'll be familiar with how to handle this. If you've had to use that for glaucoma valves or you've had to use that for corneal perforations or melts or whatever, similar concept in terms of how it handles. So you're going to receive that here, a couple little pearls. The first thing is that as it comes in the medium, these things are transparent and they're small. So you want to make sure that you don't lose it. And so you got to make sure it may be on the back of the cap, it may be on the inside of the cap, and it might be stuck to the inside of the bottle. So you're going to decant this into the strainer that's going to come in the package, okay? And then you're going to rinse it. And 9 times out of 10, it won't be in there. It'll still be in the bottle. You put a little bit more fluid in, you decant it again. If you need a little Q-tip, cotton tip applicator to bring it out, you got it. So my feeling is that rinsing is absolutely critical. Absolutely critical. And I am obsessive about it. And this has been a great procedure, wonderful procedure, but I'm hearing from some people starting out that they're getting some tissue reaction. They're calling it tissue reaction. I haven't seen tissue reaction. I've not seen vascularization. I've not seen, much in the way, some edema, early post-op, but I'm not seeing inflammation, fibrosis, or scarring. So a lot of us that are doing this suppose that the tissue is not thoroughly rinsed. So really make sure that that tissue is clear of any storage medium that's not meant to be put into the channel. Okay, so this is your tissue. Now a question comes up, do we dehydrate it or not? And Shadi Awad had shown the jerky technique with fresh tissue, dehydrating it so that it's a little bit stiffer to implant. I haven't found it necessary for CTAK tissue. It is, it's got enough rigidity, because of that gamma irradiation. But, if you want to go an extra step, then you can let it out to hydrate. And so, for example, I'm showing, Dr. Kirk and I are doing a wet lab together in a minute. I have the tissue here dehydrating. And that's usually my workflow. So what I'll do is before I scrub, I'll have a back table, Mayo stand, right? And I will prepare my tissue and leave it to dehydrate, and then I'll go to cut with my femtosecond laser. If I'm doing it at the same time, that is. I'll then cut my, my channels. These are our marks. Okay, so these are just preset calipers. And these instruments come from Corza, or Katina used to be. So they'll have a preset width. So from about like 1.75 millimeters or 2 millimeters all the way up. So you're gonna use that to judge the pupil center and your offset. And the marking, I remember when I was first learning, the marking was the part that was the most confusing to me. Is the marking making sense, or should I specify a little bit more? I'm gonna specify a little more. So you put those marks on based on those inferior, infratemporal, and temporal, or whatever, nasal offsets. And you mark from the pupil center down to where the internal rim of that CTAK tissue is gonna go, right? So going back a little bit, these are the marks that we're using. So my caliper is I'm gonna choose here, this is 218, probably gonna round that up to 2 1/4. This is 2 1/4 for me, it's 228, I'm gonna round that to 1/4. This is 237, I'm probably gonna round that to 25, especially in that the cone is a little bit inferior. So I'm gonna decenter it. We're not centering these on the pupil, again, we're centering them on the cone. The cone's here. So it makes sense for this to be a little bit more inferior of an inlay, right? So that's what those marks are. So we mark the eye, and then once the eye is marked, we're then gonna use an optical zone marker. So this optical zone marker, in this case, again, it was a 4-5 inner diameter. So this is just a 4-5 stamp. And it's using those marks that I had made. And then when I see those 3 marks, inferior, infratemporal, and so forth, I put that optical zone stamp on top of it, and I've got a nice ring that's gonna guide my femtosecond laser to cut exactly where that I want to. So you can see here, it's decentered inferior, right? And that's my goal. Here we are under the femto laser. So by the way, I would recommend creating the channels with femtosecond laser. There are some that are talking about creating these channels manually. It's a little bit more work, plus CTAK is wide. So those manual intacs instruments, some of those dissectors are thinner. You could do multiple passes, but I think if you've got you're gonna just have a much, much easier time if you've got a femto laser. So your rep can go through all of the settings of the femto laser. It's pretty well worked out. And this is what it's gonna look like under the laser. You're gonna center, again, not on the pupil, but you're gonna center on that optical zone mark that you've established. And this is, for example, on the FS200, which is my Femto-LASIK platform. And that creates a 360-degree channel. There are other lasers that don't create a 360-degree channel, but generally 360-degree channels are gonna be easier for you because you've got to access, regardless of where this inlay is gonna sit, you're gonna be accessing it, right? So 360, I don't have any problem with that. But if you can, if you have laser software to do a smaller arc and you don't need that other segment, go for it. But most of us are cutting 360. And then the side cut. The side cut is made about 15, again, this is given to you, it's made about 15 degrees off from where the edge angle is gonna be, so that the edge angle of your inlay is nowhere near that side cut. Otherwise, it might pucker a little bit. So 15 degrees is a reasonable amount. I use 30 personally. So I just move that edge angle a little bit over just so that the inlay is not near it. 15 seems fine. So here's what that looks like. We're gonna just open that up. with a channel dissector, and some of these instruments are maybe from your LASIK tray. Otherwise, Corza sells a really nice set of instruments, including this dissector. This is a really nice dissector because you can look right down the barrel, and you can see exactly what you're doing. So here's the Corza instruments being used, and I like to dissect both ways. Some people just dissect one way, especially since it's already cut by femto, but I like to dissect both ways. And I like to make sure I have the full width of that channel. Some people ask whether the channel should be cut a little bit wider than the inlay, just to make your life easier. We haven't found that it's necessary. If you want to go 0.1 millimeter wider than your inlay width, 0.2, that's fine. Don't go smaller. Some people were thinking, okay, if I get a tighter channel, then I'll have more puckering and more flattening of the tissue. But it can be problematic. It can put some pressure on your roof of that channel. By the way, these are typically implanted about 200 microns deep, so that's what we're setting. And as compared to intracorneal ring segments, okay, so that's substantially more superficial. And that's what's so cool about this procedure. Not only is it biocompatible, but because it's superficial, we're getting a lot more shape change on the anterior surface of the cornea. Right? If you take a look on OCT, anterior segment OCT of intracorneal ring segments, you can see a lot of the shape change is posterior. And yes, the posterior cornea contributes to refractive change, but not nearly as much as the anterior cornea, right? In terms of, it's almost like 80 times more important, the anterior cornea relative to the posterior in terms of the overall refractive impact. So that's part of the reason that CTAK is so effective as compared to that. And this is what that segment looks like. I typically keep the surface a little bit dry at this point, just again, not to overhydrate the segment and make it too noodle-like. But again, it handles pretty well. And you'll see these, you'll see this live as we do the cases as well. But we're able to move this through, and it's moving through, relatively easy on its own. And then with forceps, I'm starting, and then I really like this applanator tool. This is great, really smooths it out because you really have to watch for stria in these CTAK inlays, or really any inlay, right? So smoothing it out is making sure that those that inlay is all the way expanded out, right? And that you don't have stria. And by the way, I've moved as well to pre-marking. I skipped this step, but I pre-mark these patients at the slit lamp as I'm just, giving them their sedative or whatever, with that edge 1 and edge 2 angle. And that's helpful because they're upright. I'm not worried about cyclotorsion. And then I know exactly where this inlay should sit. And if it's not all the way to the edge 2 angle, then I know that I haven't stretched it enough, right? So that's my easy sign that I've got a stretch, or I may have some stria. Just like when you're doing LASIK, you may have some gutter issues from one side to another. So we're going to smooth that out, and yeah, and then you can use a BCL on these cases if you feel the need, if you've kind of messed with the cornea a little bit and you're worried that this patient may have a little bit of dry eye or maybe even abrasion, but otherwise it's not strictly necessary. And then postoperatively, here you can see, again, relatively close to the visual axis. And here again was that pearl on marking. So you can use a toric placement marker. That's one intraoperative thing that you can do. I just simply use like a Viscot marker, a surgical marking pen, just right at the limbus when the patient is sat upright for me. Postoperatively, everyone's a little bit different. Mine drops something like PRK, surface ablation, antibiotics for a week, or at least until you see that side cut in that channel is completely closed. And then I steroid taper depending on how much edema I have and whether or not I see any amount of tissue reaction at all. And usually I'll use prednisolone acetate or something like that for the first month in a 4-3-2-1, and then maybe I'll move them to a Lotamax or a fluorometholone for another month or two. And I'm taking these patients off steroids. So maybe that's an advantage to processed acellular tissue, right? We're perhaps less concerned about long-term rejection because we're not bringing cells with us. And then we're rechecking for spectacles. Some patients, particularly if you took someone very advanced, you may still fit them for RGP. And so this gets into a little bit on counseling, right? I don't promise patients this is going to be as good as your RGP lens. There's nothing on earth. You guys all do cornea. There's nothing on earth as good as an RGP lens, right? But there are two benefits. If we can raise their uncorrected and their best spectacle corrected acuity, we're raising the floor for somebody that's perhaps still using RGPs. So now, if they're only wearing it 8 hours a day, they don't have to give up on being productive, using their computer, watching television for those hours that they're not. For mild to moderate cases, you have a very high probability of not needing any form of scleral contact lens or RGPs. So it depends on the severity of the case, but most mild cases, I'm more than likely not going to need an RGP. Moderate cases, it depends on the patient and how, particular they are. Moderate to advanced and pre-counseling, hey, you may still need this, but by the way, your RGP fits are going to be so much better after you have flattened the cornea. So much better. And so, yes, we have advanced technology, scleral lenses, right, to fit these crazy, wacky cones, but those are much more expensive than a hybrid lens, and they're out of the reach of some of the patient population that comes in with keratoconus, right? Secondary procedures, also very, very useful. So phakic IOL sometimes pair great with these patients. Lens surgery, toric IOL implantation, sometimes topo-guided laser. CTAK does not replace cross-linking. So, you still, if you have a patient that's progressing, you still need to, in your protocol, decide when and where to cross-link. You can either do it together if insurance will allow, okay? Or you can do as I do, which is I do the CTAK first, and then I cross-link later to sort of lock it in. If your patient's already cross-linked, you can still do CTAK and you'll still get a shape change. There's nothing that much more difficult because the femto is creating your channel, and you're still gonna be able to get it in. It's not so much different, but if you were manually dissecting that channel, I could see that would be hard. This was one of my first cases, super advanced, definitely not your ideal first patient, but he was about to go for a PK because his K-max was almost 85, 90 diopters. But how do you take a guy with a clear cornea for a PK? It feels wrong, or a doc, it feels wrong. My scleral contact lens fitter was saying, and she's excellent, she's like, I just can't get him fit. What can we do? Have the graft, send him back to me for a scleral contact lens otherwise. And CTAK was just starting, so I was like, look, we have nothing to lose. We did this case. You've seen his surgeries already. We mark, we cut, we implant. It was a very large, thick arc. Post-operatively, this is 1 week out. He looks like this. And he goes from 2400 best spectacle corrected acuity to 2060 uncorrected and best corrected. He has a massive 22 diopters of flattening, right? And this is what it looks like. Those inlays on anterior segment OCT, right? This is our epithelium thickness map as well. The pachymetry showing here where that inlay is laying, and you can see it's thicker in those areas. So he did wonderful. So I did send him back to the scleral contact lens optometrist. She was able to fit him, no problem. 2025. He doesn't even wear them all day. He wears them when he needs to. He accepts his 2060 when he doesn't. That's a super advanced case. I just show it, not because that should be your first case, but so that you can see the power of the procedure. Much more straightforward case, I would say, would be somebody like, I'm going to skip this one. I'll show a different one. Someone like this is a 65-year-old physician, post-LASIK ectasia. My partner had cross-linked her some years back. She never could wear an RGP, didn't want to wear spectacles because she's had so much anisometropia. 2040, but she walks around 2200 because she can't tolerate specs, and she comes with a cataract. So he sent her to me for like a pinhole IOL or something like that with her cataract. I said, okay, well, let's try to reshape the cornea first. This was our surgical plan. This is the inlay. This is her 2 months later. And this is what we achieve. 12 diopters of flattening, but importantly, our astigmatism is much more orthogonal. And now we're going into cataract surgery, right? What did I do next? High-powered toric IOL, 2030 uncorrected. And so this was never accessible to her again. So she went from not using this eye to walking around 2030 uncorrected. She's a physician, she's an ER doc that was using one eye to do procedures. And there she is now. So we talked already about patient selection. I'd say moderates, right? Avoid too peripheral a cone to start because again, it's not centered on the pupil, it's centered on the cone. If you're really peripheral, you can push that CTAK inlay out towards the limbus. It'll be a little bit harder for you to dissect. So do a few more central cases and then take that on later. We'll skip the education on patient self. I'm happy to talk with you all about how to counsel your patients. We got into it a little bit. You really want to set expectations. This is a great surgery, super powerful. It is not a cure-all, right? There's still a role for cross-linking. There's still a role for secondary procedures, ICL, toric IOLs, topoguided PRK, RGPs. There's a role for all that, but this is just something I've been really, really excited about having on offer to the patients.